This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Hangover. Want to know what disease is more common in the emergency department in the month of January? Has been called Jitterbug? And why veterans hospitals used to have whiskey on the formulary? Then listen to find out. This is the third and last part of our toxicology holiday miniseries. Today's episode starts in a restaurant. You and your friends started this post-holiday tradition several years ago. Everyone who has to work during the holidays gathers to spend time together afterwards rather than during. Around the table, everyone is laughing and enjoying themselves while eating pizza and pasta. You're exchanging stories from the trenches about difficult cases when you notice one friend become pale and sweaty. He's a lawyer, so you immediately apologize for discussing a case that involved copious amounts of blood, forgetting ER stories aren't always appropriate for conversation during dinner. He brushes off your apology, saying he's not bothered by the conversation, but rather isn't feeling well. You ask what's wrong. He says he's been under the weather and might be coming down with the flu. A few minutes later, there's a huge bang. Your friend has fallen out of his chair. You jump up with a crash as your own chair falls backwards. He starts convulsing, having a generalized tonic-clonic seizure. Question number 1. What do? A. Put a spoon in his mouth so he doesn't swallow his tongue. B. Hold his neck still. C. Roll him onto his side. The answer is C. Try to roll him onto his side to prevent choking and aspirating. Don't put anything into his mouth. This might cause more harm than good. And don't try to hold him still, as you might inadvertently cause injury. Another friend calls 911. You ask if anyone knows if he has a history of a seizure disorder. Everyone shakes their head no, including the person who has known him for 10 years. After 2 or 3 minutes, the seizure stops, but he remains unconscious and tremulous. Medics arrive and transport him to the hospital. Once again, of course, we wouldn't be his doctor, but this is a fictional case, so you need to figure out what's happening to your friend. In the ED, his vital signs are as follows. Temperature 98.5 Fahrenheit or 36.9 Celsius. Heart rate 130 beats per minute. Respiratory rate 22 breaths per minute. Oxygen saturation is 100% on room air, and his blood pressure is 190/70. The nurse removes his urine-soaked pants and gets him into a gown. He has a contusion, a lump on the back of his head from the fall. He's opening his eyes, but he's not following commands or talking. His heart and lungs, other than the rapid heart rate and rapid breathing, are normal, and he's moving all of his extremities. As you examine him, he becomes more awake, but also starts to become agitated. He's thrashing on the stretcher and trying to pull off the cardiac monitor leads. He clearly doesn't recognize you or understand he's in a hospital. You haven't completed the physical exam, but you stop here because it's increasing his agitation and becoming counterproductive. This isn't unexpected behavior, and it's most likely a postictal phase due to the seizure. Patients can be unconscious, lethargic, confused, agitated, and aggressive after seizures. So instead, let's start the workup, give him a few more minutes to recover, then come back for the rest of the physical exam later. So what has happened to our friend? Could this be new onset epilepsy? It's always possible, but he's 37 years old, and that's relatively old for new onset. And if it's not epilepsy, was the seizure provoked by something else? By what? The obvious answer here is trauma. Anytime you have serious head trauma, there's a seizure risk, both from the trauma itself, and if there's a bleed or an intracranial hemorrhage, that also can cause seizures. So maybe he seized because he fell out of the chair and hit his head, but why did he fall out of his chair? I mean, accidents happen, but he's not 90, and this seems like a lot for an otherwise healthy 30-year-old. He did say he was under the weather, maybe coming down with the flu. Can the flu cause seizures? Sure, any infection can cause seizures, including meningitis and encephalitis. That said, he wasn't coughing, febrile, or really anything else. So while again, not impossible, a person well enough to go out to dinner is not the person with a random seizure from infection. Did I hear you asking for a blood sugar? Excellent question. As we've previously discussed, high and low blood sugars can certainly cause seizures. The medics checked his blood sugar, and it was normal. He does need a head CT and labs, including electrolytes. I'd also order an EKG to screen for risk factors for arrhythmias, which can be a seizure mimic. An infectious workup is indicated, though likely low yield, but you'd still send flu and COVID swabs, do a chest x-ray and a urine specimen. Strokes and tumors can cause seizures, but this is a toxicology podcast, so let's focus on toxins. The list of medicines causing them include antidepressants, bupropion especially. It was withdrawn from the market initially due to this side effect of causing seizures, though the FDA later reapproved it at lower therapeutic doses. Tramadol is an opioid that, unlike most others, causes seizures. diphenhydramine or Benadryl, but you have to take high doses in most cases. Alcohol is definitely a culprit. There were several bottles of wine at the table, but our friend declined, saying he wasn't drinking. Sympathomimetics like cocaine, methamphetamine, and amphetamine are definitely implicated. Is he using drugs, perhaps? Well, it's always a possibility, but you'd like to think as a friend and a physician you'd have noticed other symptoms. Bottom line, the differential diagnosis list here is long and I could go on, but nothing really seems to fit exactly. His results come back all normal, including his head CT. You return to his room. He's awake and now cooperative, allowing you to finish his exam. You ask him to open his mouth, noting abrasions on his tongue, secondary to biting it during the seizure. You also see sinuous movements along the sides of his tongue. His neurological exam is unremarkable except for this ongoing shaking and tremulousness. He starts talking, but not to you, but to someone else. Except there's no one else in the room. When you ask, he points to the chair next to his bed, the empty chair, meaning he's now awake but hallucinating. He continues to have a rapid heart rate and high blood pressure. Putting this together, hallucinations plus tremor gives us the diagnosis. Question number 2, time to pick your poison. What is the diagnosis? A, cocaine use. B, alcohol intoxication. C, methamphetamine use. D, alcohol withdrawal. The answer is D. Unfortunately for our friend, this is a classic case of alcohol withdrawal, and more importantly, it's a very dangerous complication, delirium tremens or DTs. Unlike opioid withdrawal, this is a true medical emergency. This really isn't a diagnosis we want to make in a friend, so is there a test we can send to confirm? No. The diagnosis is based on the clinical exam in conjunction with the history. Currently, the history is lacking, as is often the case in emergency medicine, but the symptoms fit and I wouldn't hesitate to treat before it gets worse. Question number 3, what is the treatment for alcohol withdrawal? A, alcohol. B, benzodiazepines like diazepam or lorazepam, i.e. Valium and Ativan. C, barbiturates like phenobarbital. D, all of the above. The answer is D. All of the above are useful to treat alcohol withdrawal. Patients with alcohol use disorders routinely, of course, use alcohol to stave off withdrawal themselves, like a morning eye-opener, for example. And in fact, liquid alcohol was on the VA hospital formulary at the veterans hospitals as late as 2006, including beer, wine, and whiskey. In most hospitals, we use benzodiazepines and barbiturates for DTs. More on this in a bit, but first, let's start treatment. Both oral and IV routes are acceptable, but since our patient is in frank DTs and has already had a seizure, I would move right ahead with IV treatment. There are tons of different protocols regarding choice of drug, frequency, and pluses and minuses of all these things are routinely debated by toxicologists. Drug shortages further confound the issue. The bottom line here, treat early and treat with high doses. I'd probably use IV diazepam if it was available because its time to onset is fast, but lorazepam or any other benzodiazepine will work just fine. Atypically in medicine, this is no time to start with a low dose. These patients have high tolerances to alcohol, obviously, and cross-reactivity means they also have a high tolerance to both benzos and barbiturates. For example, I often start with 20 milligrams of diazepam or Valium and double the dose every 20 minutes until the symptoms are under control. What is symptom control? Again, there are different scores for grading the severity of alcohol withdrawal, but in the ED, my main goal is normalization of the vital signs and resolution of tremulousness and tongue fasciculations. Patients with serious alcohol use disorders and severe withdrawal may require thousands of milligrams of benzos. You heard me right, even as much as 2,000 milligrams. And if high doses of benzos aren't working, I'd switch to barbiturates. So you order 20 milligrams of diazepam IV for your friend. While we wait to see how this works, let's take a step back first and talk about alcohol withdrawal, what happens in the brain, and then how treatment helps. The syndrome of alcohol withdrawal was recognized as far back as the 1st century BCE, with Pliny the Elder writing about trembling hands, haunted sleep, and unrestful nights. According to records from New York City between 1902 to 1935, an estimated 2.5 to 5 admissions per 1,000 New York City residents were for acute alcoholic delirium or alcohol withdrawal. It was a huge problem, and the mortality rate was 50%, due in part to treatment with supportive care, bed rest, cold baths, and opium. Slang for DTs back in those days included colorful terms like pink elephants, the rats, jitterbug, and bottle ache. Debate about the cause of withdrawal. Was it alcohol use itself? withdrawal, or underlying psychiatric disease, continued into the 1950s when the question was definitively answered during a research study. Brace yourself here because I'm about to discuss some of the dark corners of medicine. Incarcerated men were exposed to alcohol for 6 to 12 weeks, followed by a 2-week period of forced abstinence. 2/3 of the men developed elevated heart rate, sweatiness, and hallucinations consistent with DTs. Several had seizures. The prisoners were apparently volunteers, and all were, quote, former morphine addicts, end quote. Obviously, this type of study is completely unethical, but it did answer the question as to the cause of DTs. Let's take one more step back to discuss changes in the brain due to chronic alcohol exposure. Alcohol works by stimulating GABA receptors, a major inhibitory neurotransmitter, and this is the reason you become sleepy and eventually unconscious with heavy drinking. Chronic exposure results in downregulation of GABA receptors. Essentially, trying to stay awake, the body reduces the total number of receptors reflected in tolerance. Patients can drink large amounts before exhibiting the usual side effects. Alcohol also causes changes, increasing the effects of glutamate and excitatory NMDA receptors. So withdrawal of alcohol, therefore, causes overexcitation due to an imbalance of not enough GABA and too much glutamate from NMDA receptors, resulting in the classic symptoms of high blood pressure, fast heart rate, agitation, shakiness, seizures, and delirium. Now, alcohol withdrawal isn't just DTs. It's a very large spectrum. A few hours after stopping drinking, some patients might feel anxious, jittery, and unwell. This can be called alcoholic tremulousness. Some patients develop alcoholic hallucinosis, which is hallucinations alone. Think like the pink elephants. This is different than DTs because they aren't delirious and they don't have vital sign disturbances. About 10% of patients have withdrawal seizures, which used to be called rum fits in the past. And then untreated withdrawal can progress all the way up to DTs, typically 48 to 96 hours after cessation of drinking. And alcohol withdrawal isn't just a historical problem. Current data suggests 20% of ICU admissions are due to alcohol-related complications. And the presence of an alcohol use disorder or withdrawal is associated with an almost 2-fold increase in mortality amongst these ICU patients who are in organ failure. Vigilance is required in all patients admitted to the hospital for other reasons. Many will not be forthcoming about alcohol prior to admission. Some studies report withdrawal occurs in 30% of trauma patients and 16% of post-op patients. Development of withdrawal while in the hospital is associated with a 3-fold increase in mortality, even while you're there. So how do benzos work to treat the problem? Just like alcohol, by increasing GABA, they work very similarly. So the goal would be to eventually taper the benzos down, allowing the brain to reset, hopefully back to normal. Now, some protocols use phenobarbital as a first-line agent rather than benzos. Why? And that's because barbiturates act directly on the GABA channel, while benzos act indirectly. So some say that barbiturates are better first-line agents. Either way, both are mainstays of treatment for DTs. And as a side note, this means they themselves can cause withdrawal. And it looks the same as alcohol withdrawal, acts the same, and is similarly life-threatening. So the treatment for benzodiazepine or barbiturate withdrawal is restarting the medicine, then tapering off very slowly. There are a lot of other adjunctive agents we can use to help. Gabapentin and clonidine are 2 common drugs, just to name a few. Both are sedating, and clonidine slows the heart rate and lowers the blood pressure. They shouldn't be used instead of a benzo or a barb for seizures or DTs. And then interestingly, there's some new data suggesting semaglutide or Ozempic reduces alcohol cravings. So I'm sure we'll see more about that in the future. There are a lot of pitfalls to watch out for when treating alcohol withdrawal. First, never use regular antiepileptics for withdrawal seizure. That just isn't going to work. And the second is don't diagnose alcohol withdrawal and stop there. Why not? Because frequently patients with alcohol use disorders become too sick to drink and not the other way around. So in addition to DTs, a patient may have intracranial hemorrhage, gastrointestinal bleeding, meningitis, other serious infections, liver failure, electrolyte disturbances, and that's just to name a few. Thanks to alcohol's chronic effects on the immune system, you might not even see fever or other expected signs, so you have to be, as I said, very vigilant in looking for comorbidities. Question number 4. A patient can have withdrawal with an elevated blood alcohol level. A, true. B, false. The answer is A, true. Thanks to habitual exposure, users have high tolerance, so you don't need a level of 0 to have withdrawal or DTs. In the United States, the legal blood alcohol limit for driving is 0.8 or 80 milligrams per deciliter. I've had patients in DTs with an alcohol level of 400 milligrams per deciliter. Those people are in withdrawal when many of us would be otherwise unconscious with a level that high. So back to our patient. You've been dragging your feet at your computer and checking in on the other patients. It's time to stop avoiding a difficult conversation with your friend. It's hard to predict his reaction. It could range from outright denial, anger, shame, to anything in between. So first, you assess his mental status. He's calm and no longer hallucinating. His vital signs are almost back to normal with a heart rate of 110 beats per minute and a blood pressure of 135/65. The tremor is gone. He's gotten a total of 160 milligrams of diazepam over this time, so I'd say this is pretty good symptom control, and I'd be satisfied with the dose for now. You ask him how things are going. He says terrible, but isn't otherwise forthcoming. Finally, after many questions on your part and few answers on his, he says he'll confide in you if you promise not to write anything in his chart. He's been having a difficult time at work, drank excessively at his holiday party, and insulted his boss and most of his colleagues. He is expecting to be fired, and in the hopes of saving his job, he stopped drinking 2 days ago. He admits to drinking a bottle of vodka daily for the past 6 months due to these pressures at work. He's wanted to seek help, but is terrified of being disbarred or facing other legal repercussions. You admit him to the ICU for ongoing benzodiazepines, treatment, and monitoring. You also call the substance use psychiatrist for help with both treatment as well as minimizing repercussions. She says your state has a lawyer assistance program to help address these issues. You and your friends have another get-together in 6 months, this time at a spa, to celebrate your friend's 6 months of sobriety. This is a fictional case, as are all our cases, to protect the innocent. We do see a lot of alcohol withdrawal in the emergency department, especially after the holidays. If you are suffering with an alcohol use problem and want help, don't try to do it on your own. Talk to a medical professional or call the Samson National Helpline at 1-800-662-HELP for assistance. The last question in today's podcast. What author may have died from DTs? A. Ernest Hemingway, B. Truman Capote, C. Edgar Allan Poe, or D. Dylan Thomas? Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.